Good afternoon. Thank you for inviting me to this meeting, Samir. I'm going to be talking about imaging in graft versus host disease, and I'll be talking about really to the non-hematologists out there. We'll start off with what graft versus host disease is and when does it occur. It's a short prelude on acute versus chronic graft versus host disease before moving on to the typical imaging appearances of graft versus host disease in a number of the different body systems that we've seen here at St. Bart's in my 4.5 years here. So this may well be very basic knowledge for a lot of you, but for the non-hematologists and potentially radiologists out in the audience, I just wanted to touch on stem cell transplantation before we start talking about the sequelae of and potential complications of stem cell transplantation. So it's increasingly available treatment now, a treatment option for patients not only with hematological malignancies but with solid tumours as well, as it can reconstitute the immune system. And in the hematological malignancies, it's typically performed after high-dose chemotherapy, as you well know, or radiotherapy that's ablated the marrow. Pluripotent stem cells that were previously harvested from the marrow or circulating blood of the patient are transfused to repopulate the marrow and restore hematopoiesis. Now, there are three main types, as I'm sure you all know. The most common being allogenic in clinical practice, where stem cells are harvested from an individual who's genetically different from the recipient, but closely matched in terms of histocompatibility. The other thing that I wanted to touch upon was the non-myeloablative allogenic transplants, where potentially patients that may have comorbidities or are elderly and receive a less rigorous form of chemotherapy may then go on to have a stem cell transplant. And in these patients, they will have some residual hematopoiesis from the bone marrow that prevents pancytopenia. And as a result, these patients typically will not experience some of the opportunistic infections that the myeloablative patients may well do, but rather they're more likely to experience some of the later complications, such as graft versus host disease and hepatic veno-occlusive disease that we see. So the recovery sequence post-stem cell transplant, as you know, the first 30 days after stem cell transfusion is the pre-engraftment phase, and this is where the patient is severely pancytopenic and prone to opportunistic infection. It's really in the post-transplantation and the late post-transplantation phase, so after day 100, that we see acute and chronic forms of graft versus host disease. So that's a little prelude on, for those of you that are non-hematologists, on stem cell transplantation. Before we move on to exactly what graft versus host disease is, I just wanted to put it into context of other possible complications that can occur post-stem cell transplantation. So we've already mentioned possible opportunistic infections that can occur in the first 30 days, such as hemorrhagic cystitis or neutropenic typhlitis for that matter, and we'll touch upon that a bit later on. Compared to the more later complications post day 100, where we can get chronic graft versus host disease, which we primarily see above the diaphragm, acute chronic graft versus host disease, although seen usually in the first 100 days and is seen below the diaphragm. So what is graft versus host disease? Well, put simply, it's where the donor's immune cells produce antibodies against the recipient's tissues, namely, and can cause damage to a number of the organs, most commonly the skin, also often seen in the GI tract and liver, and we've got some cases of pulmonary and musculoskeletal graft versus host disease that I'll take you through as well. Now, when it's affecting the skin, it's quite simple. Even if they have abdominal symptoms, if you do a punch biopsy and you've got the diagnosis, the likelihood is the abdominal pathology is also graft versus host disease. Risk factors for the development of graft versus host disease from the donor's perspective are gender mismatch, HLA compatibility, previous transfusions or parity, and the source of the stem cell. Is it from the peripheral blood stem cell, which is more likely to cause graft versus host disease compared to stem cells obtained from the bone marrow compared to the umbilical cord blood? From the recipient's perspective, it's the conditioning regime. So are they completely myeloablative or are they non-myeloablative in the allogenic transplant cohort? Age as other comorbidity, and are they on any prevention, so any immunosuppression to prevent graft versus host disease? So typically, like I said, it affects the skin, where they develop a macular papular rash all over. And also, at the same time, it can affect in the acute setting, so the first 100 days typically, the GI tract. And these patients will typically present with nausea and vomiting, abdominal pain, diarrhea, and potentially liver dysfunction. And we'll touch upon that a bit later. If you have the skin rash and you biopsy it and you demonstrate there's graft versus host disease, then really the abdominal symptoms are most likely to be in keeping with that as well, and there's no real need for imaging in that context. However, we do see patients, as I'm sure you're aware, where there is no cutaneous evidence of graft versus host disease, and therefore we need to rely on the imaging. In terms of those patients that have had stem cell transplant, about 35 to 75% of patients will develop between stage 2 to stage 4 acute graft versus host disease, so in the first 100 days. So that's cutaneous manifestations as well as gastrointestinal manifestations. So like I mentioned, it typically affects the skin with GI symptoms, but in the context when it doesn't affect the skin and they've got abdominal symptoms, the first investigation or the investigation of choice should be a CT scan. In some places, ultrasound has been performed, but really CT and the findings on CT are a lot more sensitive and specific for diagnosing acute graft versus host disease. And the most common finding is that of bowel wall thickening. And adjacent in those segments of thickened bowel, you will often see mucosal enhancement, as well as excessive small intestinal fluid filling. So essentially dilated loops of small bowel that are fluid filled. If you see that, then in 94% of cases on CT, they're likely to have a gastrointestinal graft versus host disease. So this is an example of a patient. These are 2 coronal slices of a patient that had acute graft versus host disease. And what I'd like to demonstrate here is the discontinuous segments that have been affected. And that's typically seen in acute graft versus host disease in the GI tract. So in the first picture, I'll just move over, the laser's not working. You can see thickening and mucosal enhancement of the second part of the duodenum, as well as the right side of the colon. In addition to that, the transverse colon here has mucosal edema and submucosal edema within it, and it's thickened. So you've got discontinuous segments of bowel that are affected, which you wouldn't necessarily see in an opportunistic infection. Similarly, this is another case of gastrointestinal graft versus host disease, where you see the fluid-filled dilated loops of bowel that have enhancing mucosa. This is well demonstrated by the central dilated loop of small bowel that is demonstrating enhanced mucosa as well as dilated fluid-filled bowel. This is a stage 4 case of gastrointestinal graft versus host disease, where there's free intraperitoneal fluid as well. So this patient would have a reduced performance status. So as radiologists, we're often asked the question, is this typhlitis or is it graft versus host disease? these are the main two distinguishing features, really. In neutropenic typhlitis, obviously in terms of the clinical setting, if they're neutropenic, that information helps. But it affects the right side of the colon and selectively the cecum and the terminal ileum in a high proportion of patients. Whereas in gastrointestinal or acute graft versus host disease, you've got discontinuous segments of bowel, potentially segments of colon, as well as small bowel that are affected. And strictly speaking, you don't get right-sided colonic involvement in acute graft versus host disease. You may get descending colon and small bowel involvement, but the right side of the colon typically is spared. Just to touch on hepatic graft versus host disease. Now, one of the complications that I mentioned before as a sequelae of allogenic transplantation is veno-occlusive disease of the liver. That is different to hepatic graft versus host disease. Hepatic graft versus host disease is a disease of the biliary tree and typically just causes some cholestatic jaundice. If persists and untreated, can result in cirrhosis, but there are no typical features that no truly reliable graft versus host disease specific imaging findings that exist in the liver that can give you the diagnosis on imaging. So when requesting a CT, if you're querying hepatic graft versus host disease, it's one that has to be made on biopsy rather than imaging. There's no imaging specific features that will allow us to make the diagnosis for you. So pulmonary manifestations of graft versus host disease. So now we're moving to above the diaphragm, and these occur typically after day 100. And so this is a late post-transplantation non-infectious manifestation, and it has two typical imaging appearances. The first is of cryptogenic organizing pneumonia, and that's the less common form. The more common form is constrictive bronchiolitis, which is seen in up to 10% of cases. And the imaging appearances are also typically very different. The more common is where you see the mosaic attenuation pattern, and in order to really diagnose that, we ask that you, when you request the high resolution CT, you ask for an inspiratory as well as an expiratory high resolution CT to demonstrate the air trapping and the mosaic attenuation and the small airways disease, the constrictive bronchiolitis. The cryptogenic organizing pneumonia can be very similar looking to invasive aspergillosis. So you get pulmonary opacities like we have here with surrounding ground glass halo, which is the hemorrhage occurring in the adjacent lung. It's really the clinical picture and where the patient is post-transplant that will allow us as radiologists to make the distinguish between whether this is invasive aspergillosis or whether this is graft versus host disease, and whether the patient is clinically well. So that information is vital when requesting the CT. And the more common form of constrictive bronchiolitis, so this is an inspiratory, and you can always tell the inspiratory scan from the expiratory scan because the trachea will be depressed. So the posterior aspect of the trachea, you can see is depressed, is more convex compared to the expiratory phase where it's a lot flatter. And you can see these are corresponding lobes. There are areas of ground glass shadowing adjacent to areas that are normally aerated. So you've got air trapping in segments of the upper lobe in keeping with small airways disease that you typically see in pulmonary graft versus host disease. The last system that I just wanted to touch upon, because we've seen a few cases here, is the musculoskeletal system. Common presentations are those of joint contractures. You can see polymyositis or polypyrosis, but commonly, the most common appearance on imaging, as well as clinically, is that of fasciitis. Typically, you will have cutaneous findings with it, but sometimes you don't. On MR, what we look for is edema within the subcutaneous tissues, So here we have an axial stir sequence through the forearm of a patient that had arm pain post-transplant, and this is the subcutaneous tissue. All this high signaling is edema, as well as in the interfascial planes. So these fascial planes should not be as bright on the stir imaging sequences. And this is a corresponding coronal sequence, again demonstrating the high signal in the fascial planes between the musculature, in keeping with the fasciitis. And if you were to go on to perform a muscle biopsy here, that would show features in keeping with graft versus host disease. So to conclude, patients undergoing stem cell transplant are at risk of infectious and immune-mediated complications. Imaging more and more is serving as a cornerstone in the timely, accurate diagnosis of potential post-stem cell transplant complications. The type of transplant and where the patient is post-transplant is imperative in the diagnosis, or imperative in knowing when interpreting the images. And allogenic transplants develop graft versus host disease, as do non-myeloablative transplant recipients in the chronic setting. Any questions? So that was just a quick run through the imaging of graft versus host disease. The main message that I wanted to get across is that it's not just above the diaphragm. You can see it below the diaphragm, primarily pre-day 100 post-transplant. Post-day 100 is when you should be considering pulmonary graft versus host disease.